Afternoon. Welcome to the IMA leaders and all the IMA members of our Indian Medical Association. So, very good afternoon. This is the monthly webinar of IMA AMS Tamil Nadu State Branch. Today, we are going to commemorate two important days. One is the World Parkinson's Disease Day. Other one is the World Hemophilia Day. This is the program agenda. I request Dr. Adar Sendil Kumar for the physician IMA prayer and physician prayer. Over to Dr. Sendil sir. Physician prayer. Voice kekla.
Though great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give me the singleness of purpose sent to lift at least a part of the burden of my suffering fellow men and a true realization of the rare privilege that is mine. Take from my heart all the will and willingness that with the simple faith of a child I rely on thee. I am a prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every grief and love. Thank you, sir.
Thank you, Adar Sendil Kumar, for prayer and IMA prayer and all. So now, may I request our IMA AMS chairman, Dr. V. Rajesh Babu sir, for the welcome address. Dr. Rajesh Babu sir is a senior consultant, neurosurgeon, and head of the department in Ganga Hospital, Coimbatore. Sir is a former president of IMA Coimbatore, currently is chairman organ donation committee, as well as the IMA Academy of Medical Specialties Tamil Nadu chapter. So over to Rajesh Babu sir for the welcome address.
Good afternoon, everybody. First of all, I thank our president, Dr. Senguttuvan sir, for giving permission to conduct this continuous CMA for the third month we are conducting, and I welcome our president, Dr. Senguttuvan sir, for this CMA. I also welcome our national vice chairman, Dr. Amudan sir, for this program. I also welcome our office bearers, the state secretary, Dr. Karthik Prabhu sir, Dr. Sridhar sir, the president-elect 2025, Dr. K.M. Abul Hassan sir, immediate past president sir, and Dr. Gauri Shankar sir. I also welcome today's speaker, Dr. Ramanarayanan sir, who is going to give a talk on restorative neurosurgery, and also the moderator, Dr. Bhuvaneshwari Rajendran, and the other speaker, Dr. Gopinathan, Hemophilia update, and Dr. Margaret Chellaraj, the moderator. I welcome you all for this program. Regarding this today's program, Dr. Ramanarayanan sir is a senior neurosurgeon who is exclusively doing the functional neurosurgical procedures, and in this region he is one of the pioneers. Started this specialty long time back about doing Parkinsonism, and then the spinal spasticity, and so many things he is doing. And one such specialty is that the Parkinsonism. He is going to give a talk today. And regarding the IMA AMS, today actually our participants are around 110 people. Those who are having the specialties, I request you to please enroll yourself as the IMA AMS member, the Academy of Medical Specialty, because once you become the member, you can utilize the services of the Academy of Medical Specialty. Sometimes you can create the courses from your center and in your specialty like that. So you utilize this IMA AMS platform as a home for doing your activities. And also the fellowship in AMS, FIAMS also are available. The fellowship degree also is available for our members. So I invite all of you to become the members of the IMA AMS. Now is that we are having hardly around 1,700 members only. We need to increase it, at least minimum 1,000 this year. And regarding our activities, we are conducting a lot of different courses. Already we are conducting the regenerative medicine course, the laparoscopic course, and arthroscopic course. And the new courses we are going to start in 2-3 months are critical care medicine, and then the cosmetology course we are going to start, and the telemedicine course also we are going to start for the hospital management. So I invite all the people to register or enroll for these courses if they are interested in that, and become the members and utilize the services of IMA AMS. I welcome you all, one and all. Thank you.
Thank you, Chairman Sir, for your welcome address. May I request our State President, Dr. P. Sengutuvan Sir, for the presidential address and inauguration of this monthly webinar of IMA AMS. Over to our President, Dr. Sengutuvan Sir.
Thank you, Dr. Jayaraman. Respected past President, Dr. K.M. Abulasan, President-elect Dr. Sridhar, Chairman Dr. Rajesh Babu, Honorary Secretary Karthik Prabhu, Secretary AMS Dr. Jayaraman, Finance Secretary Dr. Gauri Shankar, Adar Sendil Kumar, and speakers of the day. I think AMS is doing a wonderful job creating awareness in every field. Last time they spoken about the respiration. This time they have come for the neurology, World Parkinson's Day, and Hemophilia Day. Speakers are very well established speakers. They will pinpoint the diagnosis and to how to go for the diagnosis of the neuro problems and hemophilia therapy. So everything as I pointed out by Rajesh Babu, I think IMA Athur branch will shortly open the AMS specialty wing. Almost they have collected members for the 20 members, and soon we will inaugurate this. I will inaugurate today. I will declare to inaugurate the World Parkinson's Day and Hemophilia Day. Thank you. Over to Dr. Jayaraman.
Thank you. Thank you very much, President Sir. So our President is native branch of Athur IMA. So happy to start the IMA AMS, and all your advice will follow, Sir. Thank you very much. Now I'll move on to my Secretary's report briefly. So this is our office bearers, Dr. V. Rajesh Babu Sir, Chairman, myself, Secretary, Dr. Adar Sendil Kumar is Joint Secretary. And the last month, March month, we conducted the monthly webinar to there are two important days we have commemorated. One is the World Kidney Day, other one is the World Sleep Day. There are a lot of stalwarts. We have a lot of discussion about the World Sleep as well as World Kidney Day take-home messages. So on 14th March, I conducted the Facebook live program for the general public as well as a video clippings released for our IMA members to commemorate World Sleep Day. And September, there is a March 16th Sunday, Indian Medical Association, all the Chennai branches and Chennai Villivakam branch did the awareness walkathon for World Sleep Day. Our President, Dr. Sengutuvan Sir, presided the inauguration and flagging of the event morning 7 o'clock at Elias Beach, Chennai. Followed by, we had a wonderful sleep summit at MGM Healthcare. This is a sleep masterclass and sleep workshop to commemorate World Sleep Day at MGM Healthcare. We had a wonderful 8-hour session, morning 9 o'clock to evening 5 o'clock, with the 2 TNMC credit points from our Tamil Nadu Medical Council. And this is the World Sleep Day brief events. Our President, Dr. Sengutuvan Sir, and Vice President, North Zone, Dr. Narmada Ma'am, they joined us. There is a chief guest and guest of honor, and all the other branch president, secretaries, office bearers took part in this awareness walkathon for the commemoration of World Sleep Day. And we conducted the World Sleep Summit at MGM Healthcare. This is the brief photo pictures you can see clearly here. And we had wonderful session on sleep apnea and insomnia, discussion about all kinds of sleep disorders. The chief guest of the day sleep summit was Dr. Shivani Swami from Jaipur. She is Dynamic Secretary of Southeast Asian Academy of Sleep Medicine, took part in the function, and we had a quiz program for the PGs. This program organized by the IMA AMS of Chennai Villivakkam and other Chennai branches connected in MGM Healthcare. And we conducted the sleep workshop. There are 4 kinds of workshop we conducted. One is the polysomnography, sleep study workshop. Other one is the non-invasive ventilation, that is a positive airway pressure, PAP devices workshop. Other one is the drug-induced endoscopy and nasopharyngoscopy workshop for the ENT perspective of sleep apnea. And the mandibular advancement devices from the maxillofacial perspective, oral perspective. We had a 4 wonderful workshop on the day. And that is 23rd March, we participated in our state council meeting at Chennai, hosted by Chennai IMA South branch. And we released the TOMS Bulletin, Tamil Nadu Academy of Medical Specialties Bulletin. This is a quarterly newsletter from IMA AMS. So this copy is released by our president, Dr. Sengutuvan sir, and the copy was released by all our leaders. There was an online, there is a soft copy was distributed all our IMA group for member benefit. This TOMS Bulletin, which contains all about our activities and the webinar program, this abstract papers, all in detail, and the program detail was there in the TOMS Bulletin. Kindly go through. Once again, I will post in all our WhatsApp groups. And for the commemoration of World Tuberculosis Day, 24th March, I conducted the Facebook Live program for the public, as well as video clipping was released for our IMA members. And Dr. our Chairman Rajesh Babu sir, our IMA AMS Coimbatore chapter, and our Chairman Tamil Nadu chapter conducted the Neuroscience Forum with the IMA Coimbatore branch, conducted the topic on anti-epileptic drug medications and overview of epilepsy surgery techniques and all. And this is our own Chennai IMA Villivakkam Enavaram branch monthly meeting of our AMS. So sponsored by SIMS Hospital, we conducted the wonderful CME program last Sunday. So with that, so this is all the IMA AMS Academy of Medical Specialty courses available. Already our Chairman Rajesh Babu sir told about that. So those who are having the specialty in our hospital, kindly look into that and start your branch and form the course module and send to the Chairman Rajesh Babu sir. We will decide and forward it to our headquarters for approval to start these kind of courses. There are more than 45 courses are available. Very soon we are going to start the cosmetology and critical care course and all. So these are the courses for the past 2-3 years we are conducting under the banner of IMA AMS laparoscopic course, diabetic retinopathy course, infertility course. These are all the 6 months to 1 year short-term courses, orthoplastic course, Regima, that is regenerative medicine, IMA. This is 1 year courses. And in Chennai, we had 2 courses, Sleep Med IMA, already 4 months is going to complete now. So next batch will be starting after the approval from June 2025. And laparoscopy course available at Bilrath hospitals. I request all, so kindly join these courses. We are waiting to start the course very soon in the Bilrath Hospital, Chennai. This is a Sleep Med IMA 2025 fellowship course in sleep medicine. This 6 months course, online and offline, not a hybrid. First Sunday online, second Sunday offline. So such a way we are going to design. Coming Sunday, we have offline class at MGM Healthcare, Sleep Med IMA classes. And this sort of application form. So the fees is 35,400 inclusive of GST. This is the application form. Kind request everyone kindly go through our Timon newsletter, which contains all about the application form, everything. Any queries, please feel free to contact our IMA AMS, myself, Jay Raman, or Adar Sundar Kumar, or our chairman, Dr. Rajesh Babu sir. And the very important message, so tomorrow is the last day for our membership drive for our IMA. With the 25% concession, state as well as national, kindly utilize this opportunity. So membership drive is very important. I request everyone, those who are not joined in Indian Medical Association, your colleague or your wards, your family members, so kind request to join in IMA and IMA AMS. The IMA AMS fees one-time life membership fee. AMS fees is just 1,180 only. Already our chairman told clearly about that. Welcome to join. So This is another important international conferences along with the Southeast Asian Academy of Sleep Medicine. Our IMA is going to join. Commonly, we are going to conduct the 3 days conference at Chennai. I will update. Stay tuned with this reference to this sleep conference. So with this, I conclude my talk. May I request our national and state leaders for the felicitation. May I request our IMA AMS Headquarters Chairman, Dr. Ramneet Singh Bedi, sir. May I invite our Vice Chairman of IMA AMS Headquarters, AMS, Dr. V. Amudan, sir, for the felicitation. Amudan, sir.
Good evening, my dear friends, respected President, Dr. Singhatun, sir, and the learned AMS leaders, Dr. Rajesh Babu, Dr. Jayaraman, and others, and my dear colleagues. IMA AMS Tamil Nadu State Branch is doing wonderful work, and I wish they will continue the tradition of having the best state branch this year also. Only thing is that you have to insist on becoming member of the IMA AMS. So please insist on the members to write the IMA AMS membership number also, so that you can enter that. If you have the AMS number, you give them credit hours. So that will be an inspiration for the youngsters to join IMA AMS. And we should conduct the annual conference of IMA AMS. So please discuss with Rajesh Babu and our president for the feasibility of putting up this proposal at Dehradun tomorrow in Central Working Committee meeting. With this, I wish all success for today's meeting. Thank you.
Thank you, Professor Dr. Amudan, sir, for your valuable comments. Definitely, we'll follow all your advice regarding the membership drive in IMA AMS, as well as the conference, etc. Definitely, we'll follow, sir. Thank you very much. May I welcome our IMA AMS Honorary National Secretary, Dr. C. Sairam, sir. May I invite Honorary State Secretary, Dr. Karthik Prabhu, sir.
Good evening, President, sir, AMS Chairman, Secretary, and all the leaders and speakers. Respects to you all. Best wishes, Jayaraman, sir. You're doing a wonderful job. AMS team is doing a wonderful job. But I would like to impress upon one more fact that we have also passed in a state council that AMS will be coordinating with all the specialty organizations regarding the case sheet to be vetted through PPLSS to Tamil Nadu Medical Council. So that is one major thing and a very important aspect which will bring more another feather in the cap for AMS. So best wishes for everything, sir. All the best. Thank you.
Thank you very much, Secretary Sir. Karthik Prabhu sir will do all the IMA, that is a specialty wing, to collect and form the case sheet of the for the PPLSS and our purpose. Thank you very much, sir. May I welcome our Finance Secretary of State, Dr. Gauri Shankar, sir. May I invite our immediate past person, Dr. K.M. Abul Hassan, sir. May I welcome President-elect 2025, Dr. B. Sridhar, sir. Okay. So thank you all the leaders for your wonderful comments. Definitely we'll follow your advice for our improvement of our IMA AMS. Ultimately, we are aiming the patient care. Definitely we'll follow. Thank you very much. So with that, I hand over the mic to our Joint Secretary of IMA AMS, Dr. Adar Sendil Kumar, for the introduction of the topic and the moderator. Over to Dr. Sendil Kumar. I'll stop share screen. Over to Sendil Kumar, sir.
Yes, sir. I'll share the screen, sir.
Yeah.
It's visible?
Yes, sir. Visible. Yes, sir. Visible, sir.
1 minute, sir. Yes, sir. Very good evening. We are starting the webinar main session. The first topic is on the restorative neurosurgery. I would like to introduce Dr. Bhuvaneswari Rajendran. She is a senior consultant neurology and neurophysiology in Kaveri Hospital, Chennai. She has special interest in neuromuscular disorders epilepsy, sleep medicine, and stroke. She is one of the few in the country with the expertise to perform neurophysiological procedures for both adults and children. She received so many awards from IMA, TNSP, SIMACON, and she received award, Mayan Award for clinical work and charity work in 2022. She received Women and Healthcare Leader Gold Medal AM Award in 2022, and she had publications and authorized many papers in peer-reviewed journals and chapters in textbooks. Her other achievements include she was the secretary of Indian Medical Association Kaveri chapter, the past president of the Rotary Club of Madras Temple City, Chennai. She is the founder trustee of Puspam Trust, which supports the medical treatment education for the unprivileged. We welcome Dr. Bhuvaneswar Rajendran. Please, madam. Hand over to Dr. Bhuvaneswar Rajendran. Madam,
good afternoon.
Kindly share your screen. I stopped the screen. Kindly share your screen.
I don't have any presentation. I'm just going to talk. Good afternoon, everybody. Thank you so much.
We want to introduce the speaker, madam. Kindly introduce the speaker also.
Sure. I will. Yeah. Are you able to hear me?
Yes, ma'am. Yes, ma'am.
Yeah. Okay.
Yes, madam.
Good afternoon, everybody. Thank you so much. And it's at the offset, let me thank Dr. Jayaraman for inviting me for this forum. A quick before I introduce our prominent speaker, let me just quickly talk about a Parkinson's disease, just a few lines, and why we need this talk today. As you know, Parkinson's disease is a very debilitating a neurodegenerative condition. The cardinal features include bradykinesia, rigidity, and tremor. Now, the usual medication that we use for patients include your levodopa. So we replace the dopamine which is being depleted in the brain. We use dopamine agonist. Other medications include monoamine oxidase drugs, amantadine, and so on. But we all know that with time, most of these patients, as they are progressing, they can develop tolerance to these medication. They can develop dyskinesias, that is excessive involuntary movements when they have been taking levodopa for a long time. And the tremor, they could also have excessive tremor, which is not responding to the regular medications. So now we have to start exploring other possibilities to treat these patients and give them a good functional, life as much as possible. So that is where our restorative functional surgery, like DBS, deep brain stimulation for Parkinson's disease, come into prominence, because in patients who have been taking medications, who have come to the end of the road where medications are not helping, too much of wear off effect, and dyskinesias, then you have to start thinking about deep brain stimulation. We have made big strides in the field of genetics of Parkinson's disease, and there's a lot of interest about the various genetic mutations that we see in familial groups of Parkinson's disease. And of course, the very another very interesting and extremely new treatment is the magnetic resonance focused ultrasound treatment for Parkinson's. But with all this, of course, deep brain stimulation plays a very, very important role. And Dr. Ramanarayanan, as the senior neurosurgeon who has developed a functional neurosurgery as a niche area, is going to talk more about it. And he'll also illustrate the role of functional neurosurgery in various other conditions apart from Parkinson's disease, like cerebral palsy, in spasticity, baclofen pumps, and so on. Now, Dr. Ramanarayanan completed his MBBS from Trivandrum Medical College, did his MCH from NIMHANS, Bangalore, and he has worked in various medical colleges in Kerala before he moved to Singapore and UK. He has specialized in restorative and functional neurosurgery, which is a subspecialty helping restore nervous function. and it includes treatments for Parkinson's disease, even psychiatric conditions like OCD, depression, and so on. Dr. Ram Narayanan is currently consultant in functional neurosurgeon at many hospitals in Chennai, Bangalore, New Delhi, Doha, Muscat, and Kuwait. So he's quite popular all over. He has been an invited speaker in many international meetings in many countries across the world. He has many new publications, both in national and international journal, and they've been widely quoted. He has also won numerous awards, including the Gold Plaque Award by the National Neurosciences Center, Muscat, Oman, in 2006. He was awarded the Achievers Award and Gold Medal by the National Integrity Cultural Academy, Chennai, in 2011. He was afforded the FRCS by Royal College of Surgeons, England, in 2012. Best Doctor by Tamil Nadu, Dr. MGR Medical University in 2012. He is also been conferred the IFAANS, International Fellow of American Association of Neurological Surgeons, in 2015. He, as I said, he is currently engaged in doing various functional and restorative neurosurgery in many hospitals across the city, which includes treatment for epilepsy, intractable epilepsy, DBS, treatment for spasticity, and also other psychiatric illness as well. He was recently awarded the Vocational Excellence Award by Rotary Club of Chennai in 2017. So we have an extremely interesting and a laureate amongst us. I invite Dr. Ram Narayanan to give his talk. Thank you.
Thank you, Dr. Bhuvaneshwari. You can hear me, no?
Yes,
Yes,
we
sir.
can.
Yeah. Thank you,
Yes,
Dr.
sir.
Bhuvaneshwari. And of course, many thanks to my good friend, Dr. Rajesh and Dr. Jayaraman for this opportunity. Without too much wasting of time, let me go start directly the talk. Yes. So as Dr. Bhuvaneshwari was explaining, my specialty is what's called restorative functional neurosurgery. That is, okay. Can you see the slides well?
Yes, sir. Fine.
Yes, sir. Yes, sir. Yes, sir. Fine.
Thank you. So, as you all know, neurosurgery is that branch of medicines which deals with the surgical treatment of disease of the brain, spinal cord, and all that. It's grown beyond the olden days, and now there is a lot of divisions like vascular, pediatric neurosurgery, spinal neurosurgery, all these things. The infant among this is what's called restorative or functional neurosurgery that deals with the surgical treatments of the functional, that is physiological disorders of the brain. In fact, the brain is different from many of the other organs in that I'm sure, at least some of you have heard of these situations. Somebody has had an head injury. You talk to the doctor and the doctor says that there's no pulse, no BP, the patient is no respiration, patient is on ventilator, the pupils are dilated, but the CT scan is normal. And again, I'm sure Bhuvaneshwari will agree with me that we see many patients who just do a CT scan or an MRI for some other reason, and they find that they have some brain tumor or something, and they come to us asking for opinion. So the brain is different in that the function and the structure of the brain do not always go together. So that's the difference here. And that is why this part of this new subspecialization has become important. So what are the surgeries which I do in functional neurosurgery? The commonest, as Bhuvaneshwari was explaining, is deep brain stimulation. That is, this involves introducing electrodes into various areas of the brain for various pathological conditions. And this is because these are all the target organs are all deep in the brain. This surgery is called deep brain stimulation. And then we put a battery in under the clavicle and we stimulate. That's why the whole surgery is called deep brain stimulation or DBS. The surgery was first started for Parkinson's disease many 25 years back. In fact, I did my first Parkinson's surgery almost 20 years back. And from that time, the indications have been increasing. Nowadays, we operate for psychiatric problems like OCD. We operate for addiction. We operate for chronic pain like the central post-stroke pain. We operate for intractable epilepsy. In fact, I'm talking to some doctors for doing surgery for failed bariatric surgery. I do surgery regularly for autism. And of course, schizophrenia is also being looked into, but at the moment it is still experimental. Then the second surgery I do is intrathecal pumps. That is, you put pumps under the skin of the lower abdomen, just under the skin, and you can deliver various drugs directly into the CSF through subcutaneous catheters. The commonest ones used are intrathecal morphine, which is very useful in cancer pains, failed back surgery syndromes, and many other chronic pain conditions. And intrathecal baclofen, which is more commonly used. This is used in all types of spasticity like cerebral palsy, multiple sclerosis, spastic hemiplegia, traumatic spastic paraplegia, so many conditions, so many spastic conditions, so many other neurological conditions. I have experiences in operating on a few patients who have been in a vegetative state for many years, 8 years, 10 years, and all that, and have been able to bring them back into conscious state after the surgery. And I also started doing this for cerebral ascites, because cerebral ascites, as you know, is a very crippling symptom. And the patients cannot even do normal activities like eating, brushing teeth, and all that. So the baclofen pump is very effective for controlling cerebral ascites. The third surgery we do is spinal cord stimulation. As the name implies, we stimulate the spinal cord, and this is very useful in refractory angina. That is, if you take cardiac patients, if you take ischemic heart disease patients, 100 of them, about 35% of them can be treated with control of BP, control of diabetes, weight reduction, all these things, stop smoking, things like that. Another 30% can be treated, they need angioplasties. And another 25% will end up having bypass surgeries. But there is always a 10 to 15% of patients who cannot be operated or who cannot undergo angioplasty due to various reasons. Of course, I'm not going to the technical reasons. And these patients, when we do stimulate through the spinal cord, the nerves going to the heart, these people will have a very good result. Again, the same spinal cord stimulation is very useful in conditions like failed back surgery syndrome, painful diabetic neuropathy. In fact, now this was approved recently by the US FDA, and we have started doing surgeries for severe diabetic neuropathy pain. I would like to add that this is probably the only surgery which will prevent further deterioration and long-term complications, including amputation, because this is a physiological surgery. This will improve the blood supply so that over a period of 3 to 4 months, a patient has a neuropathy. Is basically the nerve supply to the blood supply to the nerves are affected, and this surgery through the sympathetic system opens up the blood supply so that you can reverse the whole process. Again, it is useful in many other conditions like severe peripheral vascular disease pain, brachial plexus injury pain, herpes simplex pain, and things like that. The fourth surgery I do is sacral nerve stimulation, where, as you know, the sacral nerves are the nerves which control the bowel and the bladder, and S2, 3, 4. These are the main nerve roots which are involved. And sacral nerve stimulation is very useful for urinary incontinence, urinary retention, which is non-obstructive in nature, fecal incontinence, constipation, some cases of irritable bowel syndrome, and it's also useful in severe pelvic pain in women. And finally, the other surgery which I do is called vagal nerve stimulation. I'm sure all of you have heard of this vagal nerve. It is seen in the neck between the carotid artery and the jugular vein. And stimulating the vagal nerve in the neck is very useful and internationally approved for both intractable epilepsy and refractory depression. So, because today is, this week is going to be the Parkinson day, and I will elaborate a little more on Parkinson disease and surgery for Parkinson. Of course, Dr. Bhuvaneshwari has already covered a bulk of this thing. I'll just go look into the surgical part of it. Parkinson disease, as we all know, is called movement disorder, and it is a commonest movement disorder. It manifests with tremors, rigidity, the bradykinesia, difficulty in walking, and all that. Treatment is predominantly by medical management, and this is very effective in most cases. But a good number of patients either come out of good control in the long term or develop side effects because of the drugs. Such patients are ideal surgical candidates. Previously, we were doing all ablative surgeries, but nowadays we use deep brain stimulation, that is DBS surgery, as a treatment of choice because it is modifiable and reversible. The indications include advanced Parkinson's disease with disabling motor fluctuations, drug-induced dyskinesias, no significant cognitive impairment or psychological problems, 5 to 10 years after diagnosis, and most important is patients understand and accept the therapy. So this is, I'm sure you can see the mouse. You can see the yellow on the picture on the right side. You can see the yellow structure. This structure is called the subthalamic nucleus, and this is the one which is stimulated for Parkinson's disease. So what we do is we put an electrode from here. This is of course the hair area. So from that top of the skull, we go down and put the electrode into the subthalamic nucleus. For other conditions, like say for dystonia and all that, we use the globus pallidus interna. This is the area where we put for other conditions. This is how the electrode looks like. It has got 4 contact points. And this is a battery, which is, as I said earlier, is put under the chest of below the clavicle. The surgery is done is under local anesthesia, and it is done through a very small burr hole. So it's only 4 to 5 millimeter burr hole. It's not a major surgery. In fact, patient goes home the next day morning, but we go so deep into the brain. So how do I know that I'm going in the right direction? So that is where we use neurophysiological, recordings from the brain, from deep into the brain. So as we go down, we record from the brain. This is, of course, the subthalamic nucleus, and this is the records we get. Initially, upper thalamus we get like this, lower thalamus we get like this. Then as we go down, we get from the subthalamic nucleus we get like this. And then when we go further down, you get what is called the substantia nigra. There you get this disordered picture. So you know that your cross is subthalamic nucleus and you can come back. Of course, this is how it looks like during surgery. You can see different colors. I use 5 channels, so you get 5 channels here. Then usually what we do is we initially do some recordings from the brain, as I showed earlier. And then to confirm that we are in the correct position of in the subthalamic nucleus, because the problem is the subthalamic nucleus is very small. It's around 1 to 1.5 millimeter size. You cannot have it's very small. So you have to put in the correct thing. And if you put medial, laterally, and all that, you get complications. For example, if you put too much medially, the patient will start getting diplopia and deviation of the eyes. If you put it too anteriorly, the patient will get, you stimulate the motor system, and the patients will start getting tetanic contraction. So you have to be very accurate in placing the electrodes. So this is a table which helps me know that how I am putting it in the correct place and how correct the electrode is placed. Most of the symptoms are improved. Tremor and bradykinesia are all improved. Independence and quality of life is substantially improved. Complications are very less than 1% of the whole surgery, about 2 to 3% chance of hemorrhage, infection, mechanical issues, and cognitive decline. This is how it looks like. You can see the 2 electrodes into the brain. And this is a connecting wire which goes to the front of the chest. And this is the APB. You can see the 4 contact points very clearly seen. And all the 4 are inside the subthalamic nucleus. This is the battery in the front of the chest. This is a post-operative CT scan. You can see the electrodes going down into the subthalamic nucleus. Now, previously, various procedures like cingulotomy and all were being used. But nowadays, only DBS is used, and that too for psychiatric conditions. So now the main indications for DBS include intractable OCD, intractable depression, Tourette syndrome, addiction, aggressive behavior in autism, post-traumatic stress disorders, and tardive dyskinesias. About alcoholism, because this is a common topic which everybody is interested in. We have got what is called this reward circuit in the brain, and the nucleus accumbens is a main area which causes the main area of the reward circuit. There have been many studies which shows that the DBS of nucleus accumbens can cause reduction in alcohol, nicotine, and heroin intake in human beings. And it is very, very, very effective. And it has also been confirmed by a lot of PET studies. This is how the nucleus accumbens. You can see here. Sorry, I'm not sure. Yeah, this is a nucleus accumbens. These are the later indications for the various DBS. One is anterior limb of the internal capsule for resistant OCD. And for dystonia, we use a GPI. The BIM nucleus for essential tremor. For anterior nucleus of thalamus for refractory epilepsy. Nucleus accumbens for obesity and addiction. PPN nucleus for control of posture. Like that. Various nuclei are used for various conditions. Now I come to the other surgeries which I do, which is epilepsy. Epilepsy is a condition characterized by occurrence of seizures with or without alterations in consciousness resulting from abnormal electrical activity in the brain. The main treatment of epilepsy is medical, but unfortunately, a good number of patients become unresponsive or intolerant to medical treatment, and then their surgery becomes an option. There are different types of surgeries. There are resective surgeries, that is removing portions of the brain like lesionectomy, temporal lobectomy and all, where you can pinpoint that this is a cause of where the seizures are produced, and you can remove the structure so that there is permanent cure for this condition. But this is not always possible, because the seizures might be coming from multiple states. So we have other surgeries which include vagal nerve stimulation. As I said earlier, we can stimulate the vagal nerve in the neck, or we can do DBS of the anterior thalamus, as I mentioned earlier. Now I come to another common topic which we all deal with in our chronic pain. Pain is of very common symptoms. Is two types, acute and chronic. Chronic pain is of longer duration and persists long after the initial injury and may require pharmacological, psychological, and even surgical treatments. We call chronic pain when the pain persists or recurs for more than 6 months, and it becomes a nuisance and does not serve a useful purpose, but can cause severe psychological and financial effects. I'm sure all of you know this. There's a pain rating scale. In 1986, the WHO introduced what is called as a WHO analgesic ladder. Actually, they introduced it for cancer treatment pain, because cancer pain is again a major problem. But now it has been used for all types of chronic pains. In fact, they recommended that every doctor should use this to treat chronic pains. The first step is actually physical medicine or over-the-counter pain medications. Then you go to higher NSAIDs or nerve blocks or psychological therapies. And if these two are not effective, you go to the third step, which includes opioids or neurolysis or thermal procedures. 80 to 90% of the patients are usually benefited by this three level of management. But there remains always 10 to 15% of patients who may not benefit from any of these things. It is in these patients that we go for higher advanced pain therapies, which are basically neurosurgical. And this includes either neurostimulation or implantable drug pumps. Intrathecal drug delivery systems can deliver drugs like morphine or baclofen directly into the intrathecal space, which can directly act on the receptors in the spinal cord. So there are some advantages. The main advantage is that the dosage is very, very less. And if you give in morphine pump, the side effects like constipation and drowsiness does not occur. There's no systemic absorption, so no problem with addiction and all in future. Intrathecal baclofen has been proved to be very effective in spasticity of various etiology and also in flexospasm pains. Just to recap the indications which I mentioned earlier, intrathecal morphine is given in severe cancer pain, failed back surgery syndrome, various osteoporotic pains, complex regional pain syndromes like painful neuropathies and all that. Intrathecal baclofen is indicated in all types of spasticity like cerebral palsy, stroke, multiple sclerosis, all this. Patients in persistent vegetative states and patients with cerebral Alzheimer's, especially in MS or in spinocerebellar degeneration. This is how the pump looks like. This is a metal pump, and there's a central portal through it can be filled through the skin, and you can fill the pump directly using this central portal. This is a catheter which goes into the CSF. This is how it looks like. You can put a pump here, and you got a catheter into the CSF. And you can deliver the advantages 24/7, 365. The drug goes on into the CSF, and the patient gets the benefit. Spinal cord stimulation, as I said earlier, we can put stimulators extradurally, dorsally on the spinal cord, and we can stimulate so that it is can be used in many conditions. It was initially approved for failed back surgery syndrome. I'm sure all of you have heard of this condition. Somebody has a back pain, goes for a spine surgery, but unfortunately, neither the pain does not go away or the pain comes back with which is worse than the original pain. Then, of course, diabetic neuropathy pain. I was yesterday talking to one of the diabetologists. He was saying that, diabetic neuropathy pain is increasing tremendously in our country. There are a lot of people who are getting, unfortunately, ending up in amputation. Then refractory angina, as I said earlier, about 10 to 15% of ischemic heart disease patients end up having refractory angina because of various reasons. It can be because of small vessel disease, or it could be because of long segment involvement, conditions like that, or different anatomy. Anatomy may be different, so that a surgery or angioplasty may not be possible. All these reasons. Then other conditions like CRPS, brachial plexus injury pain, PV, peripheral vascular disease pain, trigeminal neuropathies, all these conditions can be treated with this condition. Studies have shown that this is effective in 60 to 80% of patients. This is how it looks like. These are the various stimulators, depending on the spinal cord size. This is a battery which is put subcutaneously. This is how it looks like. This is done for diabetic neuropathy. You can see here, and that's the battery. This is done for a ischemic heart disease patient. You can see here, I put it on the left side because it's important. So sacral nerve stimulation is stimulating the sacral nerves to modulate the reflexes that influence the bowel, bladder, and the pelvic floor. The indications include urinary incontinence, urinary retention, especially non-obstructive retention, fecal incontinence, constipation, some cases of irritable bowel syndrome, especially the diarrheal type of IBS, and severe pelvic pain in women. The candidates are always decided by a trial procedure and also by comparing voiding diaries before and after the trial procedures. An improvement of more than 50% is taken as an indication for surgery. This is an electrode which is used, and this is how it looks like. This is S3 foramen. You pass the electrode through the S3 foramen parallel to the S3 nerve root. Again, these are all percutaneous procedures. So how do I know that I am in the right direction and I am in the right place? So when you are stimulating the S3, you get initially some bellows of the perineum, then the pulling sensation of the rectum, and finally the plantar flexion. Actually, the toes, the foot moves like this. This is how it looks like. You can see the two electrodes here. These are in the S3. Finally, I'll mention a few words about vagal nerve stimulation. Vagal nerve stimulation involves the use of a device to stimulate the vagus nerve with electrical impulses. It is currently approved for both intractable epilepsy and severe treatment-resistant depression, especially those people with a very high suicidal ideation. Because as I don't know whether any psychiatrists in this group, but to my knowledge, there is no treatment for medical management for suicidal ideation. So you can treat the depression, but you cannot treat the suicidal ideation. But this is only surgery which can reduce the suicidal ideation in patient, and this has been proved beyond doubt. So we always use the left vagus nerve for the stimulation, because the vagus nerve left vagus nerve does not have any cardiac branches. The right vagus nerve is not used because of same reason. As I mentioned earlier, this is usually used for uncontrolled seizures and treatment-resistant depression. So this is how it looks like. This is a electrode which is put in the vagus nerve here, and this is a battery which is put in the chest. This is how the postoperative exercise looks like. This is a vagal. This is a vagus nerve is here, so this is a stimulator here, and then this goes to the battery in front of the chest. Thank you very much.
Sir, excellent speak, Dr. Ramanayan, sir. You covered everything and the restorative neurosurgery.
Thank you, sir.
Please, Dr. Bhuvaneshwari, madam, kindly give your inputs, and then you will go to the questions by the participants.
Amazing talk, Dr. Ramnarayan, and the various areas that you have covered, and the use of restorative surgery, which brings in a new leash of life for many patients. Congratulations to you for the tremendous work. Thank you for the nice talk. Thanks. Does anyone?
Madam, shall we go to the? Yes, madam. There are questions. Any impact of solar energy and ozone on Parkinson's disease?
Yeah, I think Bhuvaneshwari will be able to answer that better.
I didn't get the question. What is the question?
Any impact of solar energy and ozone on Parkinson's disease?
See, I think there is a lot of talk about the increasing pollution and also the increasing prevalence of Parkinson's disease. But I'm not able to comment on the exact impact of the loss of ozone on Parkinson's disease. But we know that increasing pollution is also increasing the prevalence of Parkinson's disease across the world, and more so in the Asian countries where the pollution is most seen.
And actually, fertilizers, pesticides, not fertilizers.
That was the initial, yes, that was the initial thought process when it came to fertilizers. But in general, pollution is also increasing the prevalence of Parkinson's disease.
Okay, sir. Any link between COVID vaccine and the neurological led complications?
We saw a lot of complications with the vaccines, like more inflammatory conditions like encephalopathy or myositis and so on, and Guillain-Barré syndrome, more to do with the immunological system rather than Parkinson's disease. We didn't see any increase in Parkinson's cases or anything like that after the vaccine.
Amna, sir, do you want to tell anything?
Madam?
Pardon?
Sundaramurthy sir, சொல்லுங்க sir.
Sundaramurthy from IMA Chennai South.
Okay, doctor.
We teach a student regarding the protective effect of nicotine on Parkinson. Is it true or false?
There are studies which actually talk about that, but as we know, smoking has got many deleterious effects on Parkinson's disease. So, I mean, on health in general. So that is not something we will want to talk about, because there are some studies which did show that effect, but I don't think that is something that we are going to propagate in general.
There are better ways to treat Parkinson's disease. Much better ways.
That wouldn't be the message that we'll be giving general public.
Agree. Madam, one last question. Any biomarkers, madam, specific biomarkers for Parkinson's disease to pick up early?
Right now, there's a lot of research that is being done to look at, as I said, the genetic, the newly found genetics that's linked with various Parkinson's disease. That is something that people are exploring. And they are also looking at CSF studies, the increase in tau protein, alpha-synuclein, and so on. But as I said, how much of that is completely translated into day-to-day clinical work? Not much, I would say. We are still going more with the clinical science. And of course, we have certain specialized imaging techniques like the dopamine uptake scans and so on to help us and to reiterate the clinical hypothesis.
People on long-term use of statin and clopidogrel, is it protective for the Parkinson? For some other purpose they take for cardiac. Is it a protective for Parkinson or worsening? Clopidogrel and statin.
There is this entity called the vascular Parkinsonism, where patients who have had repeated or recurrent strokes who can go on, especially involving the basal ganglia and the thalamic region, can go on to develop Parkinson's signs. So in those patients, when we treat their predisposition to strokes with blood thinners and statin, definitely it does have a role in prevention of Parkinson's disease. Parkinson's disease.
Thank you, madam. I feel proud to say I'm the old student of Dr. Kanaga and Dr. Ramurthy, BRM. Thank you, madam.
Thank you.
Sir, the next question, Ram Narayan, sir.
Yes.
Yes, you told about the spinal nerve stimulation for the diabetic neuropathy.
Yes.
Yes. And any other special therapies for the diabetic neuropathy is available? What is?
No. For diabetic neuropathy, there's a lot of medical management and all that, which our diabetologists do. But unfortunately, some patients, either they cannot continue with the medical management, or they develop side effects because of the medical management. They continue to deteriorate. So in these patients, only the surgery is an option, because my surgery is not the first line of attack. It is always when the medical managements are not very effective, then only the surgery should be thought of. There is medical management. There are a lot of, the early cases and all, no surgery. It's always medical management only.
Sacral stimulation can be also be used for this type of neuropathy, or intrathecal drug therapy is better?
No. See, for neuropathy pain, because always for neuropathic pain, spinal cord stimulation is better. But sometimes spinal cord stimulation may not be effective, so you can give intrathecal morphine. Yes, you can give.
Which one is better? Intrathecal therapy is better.
No. spinal cord stimulation is proved to be much better than intrathecal morphine. Intrathecal morphine is only when spinal cord stimulation you have no option. It's not going to work.
If the patient is having cervical spondylosis with severe neuropathy, what will be the better solution for the patient?
Always try to treat if there is a treatable cause. For example, if there is severe spondylosis with severe a lot of disc prolapse and all that, think of that first, treat that first, and if still the neuropathy is persists, then we can think of all this.
Now, I want to know which one you have to start first. That's what my point of view.
The specific treatment for the spondylotic disease, like medical management or surgical management, not for the neuropathy.
Okay. Any other questions from the audience? Okay, sir. Shall we conclude the session? Jayaraman, sir. Jayaraman, sir.
Yes, sir. Yes, sir. Proceed to next session, sir. Thank you.
Yes, sir. Thank you very much, sir. Sir Ramnayan, sir, and Bhuvaneswar, madam. Thanks for the very informative session. We will move to the next session and the hemophilia update. Introduce Dr. Margaret Selraj. He is the former professor of hematology and head of the Department of Madras Medical College, Chennai. She is a consultant hematologist and bone marrow transplant physician, Kannappa Memorial Hospital, Dr. Mehta Hospital, Bildroth Hospital, Chennai. Qualified from Madras Medical College, and she worked as a junior house officer in Madras Medical College and senior house officer in Christian Medical College, and she worked as an assistant professor in various institutions and retired as the professor of hematology, Madras Medical College. Her academic achievements, awards, and recognitions include Carl von Jaisel Prize in Biochemistry, George Smith Prize in Pathology, and Bannerman Prize in Microbiology, and first certificate of honor in Physiology, Microbiology, and Pharmacology. We welcome Dr. Margaret Selraj, madam. Can you introduce the speaker? Margaret, madam. Yes, madam.
Good evening to all. Thank Dr. Jayaraman for giving me this opportunity. World Hemophilia Day is celebrated on April 17th to create awareness among the general public and also for patients, to support patients and their families. So as we all know, hemophilia is an inherited coagulation disorder due to deficiency of clotting factor. It's a hemophilia, as we all know, is a defect of coagulation due to decrease in the clotting factors. So hemophilia A occurs due to deficiency of factor 8 and hemophilia B due to deficiency of factor 9. Generally, they present with bleeds into the joints and muscles, unlike a thrombocytopenia where they have skin bleeds and mucosal bleeds. So the problem with these patients is recurrent hemarthrosis and chronic hemophilic arthropathy. I would just like to trace the evolution of the treatment strategies over the last few decades. The initial treatment in the 1950s was just whole blood. And then in the 60s, fresh frozen plasma and cryoprecipitate were administered. In the 70s, plasma-derived factor concentrate was isolated and administered. However, in the 80s, there was a dark period when these patients developed viral infections, particularly hepatitis C and HIV. Fortunately, in the 1990s,
I'd like to thank Dr. Sami Jayaraman sir and IMA-AMS team for providing me this opportunity to present about hemophilia today on foreseeing Hemophilia Awareness Day this month. And I'd like to thank my senior, Dr. Margaret Hedmin, who for the kind introduction of mine. So we all know that I think Madam gave an excellent overview of hemophilia, which is to understand with is a basic coagulation factor deficiency of factor 8 and factor 9. And basically, since these factors are not there, these patients are predisposed to bleeding. So I'd like to take of how the science is far advanced from the routine hemophilia management and what we are foreseeing in the current era is what I'm going to discuss in the next 40 minutes or so. So basically, to understand, to just give a general overview, I would like to discuss an overview of coagulation pathway and how is the intensity of disease in the general public, to touch upon a basic epidemiological facts. And how do we diagnose? I think that's quite common that we do. And how do we treat this disease? The replacement therapy, various other advanced replacement therapy options that are available in the current era, which includes the non-factor replacement therapy and the gene therapy is the talk of the town these days in hemophilia. So as you all understand, like we do come across this clotting factor and coagulation cascade day in and out in case of managing our post-operative patients. So to any patient or any person, if we have, if we sustain a vascular injury, you need to have two things in place. One is you need to have a good amount of platelet function, good amount of platelet numbers, both in quantity and quality. And second, to supplant that, you also need to have a coagulation cascade in place. So that's why platelets will form the primary hemostasis, and the clotting factors or the coagulation cascade will form secondary hemostasis. So that is why here I think Madam demarcated the difference very clearly. Platelet problems are usually a mucosal bleed, say for example a gum bleed, okay, so, or a genitourinary tract bleed. So that is how a platelet function problem presents, whereas coagulation defect problems is usually secondary hemostasis, and they usually present with muscle bleeds or joint bleeds. So this is how our pathology textbook taught us about the various pathways, the intrinsic pathway and the extrinsic pathway in human body for coagulation cascade. But in reality, is that what happens in our body is not, it's not the real nature. So we have something called as cell-based model of coagulation, where the clotting cascade doesn't happen by the sequential manner from factor 11 to here factor 10 and factor 7 to factor 10 and then finally forming fibrin. It doesn't form that way. We follow something called a cell-based model of coagulation, where all the clotting factors and the platelet activation acts simultaneously to form a fibrin. The ultimate goal is to form a good blood clot. So here we can see hemostasis is just a fine balance between, hemostasis is a fine balance between, a bleeding tendency and a clotting tendency. So that is what is the main important task of a coagulation cascade is to be. So as we all understand, I think Madam clearly demarcated this. Hemophilia is not known the day before yesterday or in the last decade. It is known since 1820s, and particularly it came to limelight because of the of this particular disease affected the members of royal family and of Queen Victoria. You can see there are in the entire family pedigree chart, you see multiple male patients getting affected with the proper disease and the female patient affected with the carrier state. And why that is? Because it is an X-linked disease. So the males manifest the disease and the females are usually carriers, but there are ifs and buts to it. To start understanding about this disease, we basically need to know these two genes. One is the factor 8 gene and second is the factor 9 gene. So here I would like to recollect the central dogma of molecular biology. So for example, coagulation factor is a protein at any point of time. So how does a protein get synthesized? It comes from the DNA to mRNA, and mRNA into protein. Since basically the factor 8 DNA, factor 9 gene, the factor 8 genetic material and the factor 9 genetic material is absent in the body, the ultimate end product of it, which is the protein. Okay, since the factory is at a problem, the ultimate product is not coming out of the body. And to which, if you see, the factor 8 gene is quite longest and lengthiest with a high volume, whereas factor 9 gene is to a smaller size gene with a lesser volume. So the ultimate end product is you don't have a functional factor 8 and factor 9 in the body, and that is why these patients are predisposed to the bleeding. Coming to touch upon the epidemiological facts, you see it's not such an uncommon disease. The incidence is almost 1 in 5,000 males at birth. Hemophilia A is quite more common than Hemophilia B, which is about 1 in 20,000. And the prevalence, if you can see, it's almost 17.1 per 1 lakh males and 3.8 per 1 lakh males, respectively, with Hemophilia A and Hemophilia B. And when I talk about this disease, since I told it is an X-linked, X-linked disease, is that the only mode of inheritance? No. There are, you can see that almost 30% of the new cases are also diagnosed due to spontaneous mutation. So that is why, you can have an increasing prevalence of hemophilia with the increasing growing population. And of which, every 4 cases out of 10 cases will have the severe form of hemophilia where they, present to you with severe bleeding manifestations. And this is to understand the general prevalence of hemophilia worldwide. We have almost 4,54,690 persons, living with the bleeding disorder, of which to know it is hemophilia A or hemophilia B, it is almost 2.7 lakhs, whereas the other bleeding disorders constitute to about, less than 1.5 lakhs. And you can see here, the pockets of hemophilia are in certain regions, of which it mainly, in the Southeastern Asia and the Western Pacific, the incidence of hemophilia is definitely higher compared to the rest of the world. And here you can see, this is just to show you an overview of how bleeding disorders evolved. Here you can see the incidence from 1999 to 2022, up until the late epidemiological data that is available. You can see the increasing incidence of hemophilia. So two things are to be noted here. One is the population is increasing. Second, we have new spontaneous mutations. Apart from the routine X-linked inheritance that we keep talking day in and day out, we have a lot of spontaneous mutations also, coming in here with increasing male population. And that is why you also see the pattern of increase in incidence of hemophilia. Again, I would like to have a deeper look at this graph. You can see here, before 2004, okay, you can see here, it is labeled as bleeding disorder type unknown, because at that point of time, you don't have ease of availability of coagulation factor testing assays. You don't have access to genetic modalities of testing. Now, up until in late 2022, you can see you have multiple factor deficiencies being identified. Apart from hemophilia A and hemophilia B, which is mentioned by the red bar chart here, you have multiple other factor deficiencies also identified in 2022, because we have now access to genetic testing and we are able to segregate each and individual factors and give treatment according to the each and individual factors. Right. And again, as I told, women will be carriers and men will be usually patients. But is that the fact always? No, since again, though women are carriers, they can also exhibit her bleeding symptom. So this again depends upon, how much amount of proteins they do secrete in the blood. Depending upon the type of gene defect, they can also have a mild hemophilic symptom. And why it is so important? Because women do have heavy menstrual bleeding. Women do have menstruate every month. So sometimes carrier hemophilic women can have a heavy menstrual bleeding, and which can predispose them to iron deficiency anemia, and there will be a lot of complications. So that is why, as a part of a menorrhagia workup, it is necessary, apart from the routine fibrinogen screening, it is also important to rule out a carrier of hemophilia as well. And again, if it come to talk about the severity of hemophilia, mainly since it is to do with the clotting factor, that is your factor 8 and factor 9, we grade this on a percentage, right? So the normal percentage is usually 50 to 150. Almost all the clotting factors, the normal range is almost 50 to 150%. That is how we grade the activity, right? So if at all, if it is a mild hemophilia, it will be between 5 to 40%. If it is a moderate hemophilia, it is between 1 to 5%. And severe hemophilia, this is the ones which are clinically concerning to us. And they are usually, less than 1% factor activity. And that is why they develop severe bleeds, of which the most common site of bleeding is your joint, followed by muscle. And the next comes the rest, which is your gut and genitourinary tract. And the only 5% of the patients do bleed in the central nervous system, which is quite, detrimental to all of us. Okay. And so the common symptom, as we talk about, so usually this disease doesn't manifest, very rarely it manifests immediately post delivery, because as I said, the most common site of bleed is usually joints and muscles. So that's why, when the toddler starts, creeping and crawling, they sustain some minor amount of trauma, and that is the usual, first symptom of manifestation of a hemophiliac patient. So they usually develop joint bleeds at that point of time. They can develop a muscle bleed. So usually that is the first symptom manifestation of any patient with hemophilia. And here you can see a significant, muscle bleed and a soft tissue bruising as well. And apart from that, some neonates do present with intracranial bleed also, which is quite detrimental because they have severe, neurological sequelae in the later part of life. And very rarely patients can also have neck bleed, throat bleeds, abdominal bleeds, GI bleeds. And this is one important complication that every one of us must remember in a hemophiliac patient. So whenever any patient of hemophilia comes with an acute back pain, thigh tingling and numbness, you need to, think about iliopsoas hemorrhage, because this is an important life-threatening situation. Unless you relieve that blood clotting or this, tamponade caused by the factor deficiency on time, it can lead to, permanent, limb compromise. Okay. So as we said, what happens, because since these people keep recurrently bleeding into joints, they go on to a progressive hemophilic arthropathy, and this leads to disability. That is a permanent disability in life, and that is a main complication of hemophilia. So having said, the overall epidemiology, clinical manifestations, how do we basically diagnose it? So basically, the typical clinical symptom itself is telltale sign of hemophilia. So any child after the toddler period, during the infancy, and after attaining this toddler period, when they start crawling, creeping, and they present to you with muscle bleeds and joint bleeds, that itself is an important sign to elicit hemophilia. And second thing is, what we do is, we do in the laboratory, the initial screening test is to do a CBC, platelet count, and platelet count and a peripheral smear examination. And third, we come to the coagulation factor assays, of which we basically do a PT, prothrombin time, and activated partial APTT test. And if you find that the values are higher, if you find the PT and APTT values are higher, so here you can see in this particular diagram, here you can see in a patient, so the clotting factors are represented by this blue boxes. Okay, so here this is the serum of a patient with hemophilia. There is no clotting factor. Okay, so now to this plasma, if we add to this, we add a normal platelet rich plasma which has this clotting factors. So this gets corrected. So that is called as a simple mixing study. So basically, in a deficient patient plasma, you are adding a platelet-rich plasma which contains clotting factors, and after its correction, after that the APTT normalizes, it goes towards deficiency. Whereas sometimes when you do this, when you have inhibitors in the patient's serum, even after adding a platelet-rich plasma, you won't get correction of a clotting time. So that is called as inhibitor. So this is not the scope of topic for today. So today we are going to only cover about hemophiliac patient, which is diagnosed by a simple mixing studies. And once we have the, once our mixing study comes positive, then we go for specific factor assays, which is your factor 8 and factor 9. And again, talking about genetic testing here, whether genetic testing is mandated in all patients of hemophilia, it's definitely not. So only to define certain genetic mutation, and in certain difficult cases, or sometimes, say for example, if they are planning pregnancy, whether how is the fetus, if they want to know about the carrier state, if they want to know about the disease status, and that is one domain where we indicate genetic testing. Otherwise, usually hemophilia is diagnosed only by a simple PT, APTT, and a mixing studies. And now the main crux of topic today here, as we said, the history of hemophilia care has improved, from bottom to now, it has come to the various factors and various therapies available to hemophilia that have come forward in the late 2020s, in the second decade of 20th century, is much promising. So here, once upon a time, only we are giving only blood transfusions, cryoprecipitates, and that led or predisposed the patient to have a lot of viral inactivations. Then we developed factors, the recombinant factors, which is recombinant factor 8 and recombinant factor 9. And ultimately, now we are living in a place where we are having extended half-life factors, and we have newer non-factor replacement therapies and gene therapy. So that is how hemophilia care has advanced. With medical treatment on one side, we also have the other supportive care or rehabilitation therapies are also equally advanced currently, with improvements in joint surgeries, improvement in physiotherapy, improvement in how we do mobilize the patient. So that is how the entire care that is given for a hemophiliac patient has improved in the later part of this 20th century. Okay, so we can divide a care given to hemophiliac patient under these 4 headings. One is a pre-replacement therapy, which is your price and polis. Second is replacement therapy, which is nothing but your replacement of your factors. Since you have factor 8 deficient here, since you have factor 9 deficient here, so whenever a patient develops bleeding, then you give factors. So that is called on-demand prophylaxis. Okay, so now we are moving more towards a prophylactic administration of factor 8 and factor 9 in these patients, where in order to prevent joint bleed, we are starting even before the joint bleed has appeared. So that is prophylactic therapy. And second is non-factor replacement therapy. So again, in the clotting cascade, if you see, you have various agonists and various antagonists. Okay, so as I said, hemophilia is not only deficiency of factor, it is a balance between hemostasis and thrombosis. So what we try to do in this non-factor replacement therapy is, You try to promote thrombosis factors and you try to come down on the anticoagulation mechanism. So that is a non-factor replacement therapy. And entirely apart from all this pole is your gene therapy. And what is basically this polis or price is nothing but your protection, optimum joint loading, ice. Ice stands for, ice pack, compression, and limb elevation. This is just to protect your, conservative management of joint. Because if you just let a hemophiliac joint bleed unattended to the supportive care, ultimately it will go to joint degradation and joint fixity. Okay, so that is why it is very important that you protect the joint, you mobilize the joint as early as possible, give ice compression, and prevent further bleed. So this is the various supportive care mechanisms that we do. And apart from that, we go on to replacement to non-replacement to gene therapy. Right? Yeah. So again, if you talk about now once the pre-replacement therapy is over, now we come towards the replacement therapy, of which we have two things here. One is on-demand replacement, and second is a prophylactic treatment that I had told. So on-demand is nothing but like in the early 90s to early 2000, late 2000s to 2010s, we were only doing this. That is nothing but your on-demand prophylaxis. That is, any hemophiliac patients comes to us with a joint bleed, comes to us with gum bleed or something. We calculate the factors and then give them. That is what we have been doing as postgraduates. Only that point of time only on-demand prophylaxis was available. But the concept has evolved now. Now we don't want any joint bleed. So we go in for a prophylactic treatment. Now it has become the standard of care. Okay. So this is a basic chart, and this is how we calculate, the percentage of factor needed for every joint bleed correction. Say, for example, this is the formula that is used. Suppose if a patient of hemophilia A is coming to us with joint bleed, the dose, the factor rise that is optimized is 50 to 60 international units. So we put here, say if at all the patient is a 40 kg patient, we put like this. So 50 into 40 into the correction factor we put. Okay, so which is approximately 0.5. So if it will be like coming somewhere around 2000. Okay, so 2000 divided by 0.5 would be 1000 BD. So that is how we calculate the factor correction here. So again, if you see the dosing, factor 8 is usually administered as a BD dose because the half-life is only 8 to 12 hours. Whereas factor 9, we usually administer it, as a OD dosing because the half-life is usually 18 to 24 hours. So this is on the formula that is being used for on-demand replacement therapy, mainly to control the joint bleeds. So again, initially when the factors came in, we have only plasma-derived factors which are virally inactivated. Now we have totally recombinant clotting factor options available. Okay, so that is totally free of the viral activations. And again, apart from factor replacement, we also do some supportive care measures like desmopressin, tranexamic acid, and epsilon aminocaproic acid. All these things, are just supportive allied care measures to your joint bleed. And again, what is the main disability in hemophilia is, as I told you, if at all, if it is a life-threatening bleed like an intracranial bleed, we can actually lose patients. Second, if you have constant bleeding inside your muscle and joint, they all become a physically disabled person, thereby, severely impairing quality of life. So we may lose the patient totally to death, or they can have severe disabling joint, like ultimately compromising their quality of life. So for this reasons, we start this prophylactic therapy starting from the early infancy. Okay, so the idea is if you are able to supplement this factor 8 or 9, the deficient factor 8 or factor 9 from the early years of age, you will be able to convert them from a severe phenotype to a So ideally, by supplementing this factor, what are you trying to do? So you are trying to convert them from a severe phenotype of hemophilia to a milder phenotype. Okay. Here, as I told you, severe phenotype is one whose factor level is less than 1%. By supplementing the factors, you are trying to increase the factor levels and you're trying to convert the degree of severity of hemophilia to a milder phenotype, and that is the newer modality. It's a newer practice that has come up in hemophilia practice, is to administer these factors as a prophylactic treatment. So again, when you see this prophylaxis, we divide them into three categories. One is primary prophylaxis, where you initiate this therapy as early as 6 months to 1 year. 6 months to 1 year, even before the 3rd year of age, before any significant joint bleed has occurred. That is primary prophylaxis. Whereas secondary prophylaxis is nothing but, after you have 2 evident joint bleeds, if you initiate, that is a secondary prophylaxis. Tertiary is nothing but, initiating the prophylaxis after a, documented joint bleed has occurred. So which we don't prefer in the current era. We are going more towards your primary prophylaxis or the secondary prophylaxis. If I say prophylaxis, what am I trying to do? Again, what I'm in a week, say for example, every day we need not administer factors. I will choose 3 particular days in a week, and I will ask them to, take factors prophylactically. So the usual dosing, that is, in our country, we follow only low dose prophylaxis, where we just give 10 to 15 international units, factor 8 per kg of just 2 to 3 units per week. And with this, we try to increase their factor 8 or factor 9 levels so that they don't develop a joint bleed at all. Okay. So what you can see here, this is the graph with our conventional factor prophylaxis. You can see here, this is the annual bleed rate without factor prophylaxis. It's almost, for hemophilia, say for example, we do calculate pain score in, any post-operative pain management. In hemophilias, we calculate annual bleed rate. Annual bleed rate is how many times a patient of hemophilia has experienced a bleed in a total span of 1 year. So that is called as ABR, annual bleed rate. So that is a scoring system which we use for determining the severity of bleed. So if you see here, without prophylaxis, if the bleed rate is almost 11.5, which means the patient has had almost every bleed a month. Okay. But with factor replacement therapy, you see it has gone down to 2.8, which is almost 76% reduction in your bleed rate. So this is a emerging standard of care. We are going in for low dose, clotting factor replacement prophylaxis, wherein you can prevent joint bleeds and you can prevent life-threatening morbidities in a patient of hemophilia. So, but the thing is, it's saying is very easy, but to practically follow it is very difficult. Imagine a school-going child who is 8th standard or 7th standard. If you ask them to come for 3 days in a week, whether they will be interested to come? No, because they have to miss their school. They may be late to school, which is very difficult to achieve. With a conventional factor that we use, because the conventional factor, as I said, it has a defined half-life. Factor 8 is it will work only for 8 to 12 hours, and factor 9 will work only for 18 to 24 hours. So we thought that, the scientists thought that there is something that you should do extra to extend the half-life of factors. And currently we have something called as extended half-life factor 8. So that I will come to it now. Like how can you increase the half-life of factor 8? The first thing is, so factor 8 and factor 9 is nothing but your protein. It's just basically a clotting factor protein. So to this clotting factor protein, they did, add these 2 things. One is pegylation. Say for example, we have in oncological drugs, we say pegyl asparginase. We do pegylation. Basically, by doing this pegylation, you increase the molecular weight of the protein. Okay, so once you increase the molecular weight of the protein, the kidney will find it very difficult to clear this, particular clotting factor. So in that way, you can increase the half-life of that particular factor 8. Again, if you see, if you do this FC fusion protein, that is FC region of, immunoglobulin IgG domain, if you fuse to a particular clotting protein, the recycling will become slow. Okay. So by these two mechanisms, what you can do is you can actually increase the half-life of factor from 12 hours to somewhere between 24 to 48 hours. So that is why you can, decrease the frequency of administration of your conventional clotting factors. So again, we have various products available by these two, extended half-life factor 8 and factor 9 products. In extended half-life factor 8, we have, so many products available, which is Elocta, Adnovi, Bay94. And in factor 9, we have again Alprolix, and all these things are available. The advantage of all of this is, the dosing schedule is very comfortable. You can, avoid school absenteeism and all these kind of, delayed work presentation and all these things. So you can try to extend the half-life of factors. Again, the very interesting thing to note here is between factor 8 and factor 9, when you try to extend the half-life, there is a large difference. In factor 8, we are able to achieve only 1.5 to 1.6 fold increase in the half-life. Whereas in factor 9, you are able to achieve almost 3 to 6 fold increase in the half-life. Do you think what is the reason for it? Anybody can just take a wild guess. they can just, we can take a wild guess. By this pegylation and, FC fusion, we are able to achieve a greater success in factor 9, whereas with factor 8, it is lesser. The only reason is because factor 8, though we try to increase the half-life of factor 8 in the body always gets conjugated with your von Willebrand factor. So von Willebrand factor has a ceiling half-life of only 15 hours time. Okay. So however, we try to increase the factor 8, since it is attached to the von Willebrand factor, we are not able to increase it much higher like a factor 9, whereas factor 9 doesn't have this problem. So that is why the extended half-life is much successful with factor 9 than with factor 8. So now for combating this problem, we have something called as F-Nestacog alpha, which is again a von Willebrand, VWF independent recombinant derived factor 8 concentrate. Now this, overcomes this problem of, ceiling effect of von Willebrand factor to factor 8 extended half-life factor. And now, we are able to, with this product, we are able to achieve almost as similar spectrum of extended half-life factor as factor 9, right? And again, in the prophylaxis, what can we do better? So one is, now we are seeing with the conventional replacement prophylaxis, we are seeing with this extended half-life factor. And now what can we do really better is, we have non-factor therapy. So till now, we are trying to replace only the deficient protein, which is by, supplementing a deficient factor 8 or factor 9 with the help of a simple factor concentrate or an extended half-life concentrate. Now, can we switch over and do something different? Okay, we have something called as non-factor therapies that are available, of which the first and most common thing that is talked about is emicizumab. So emicizumab is, why we have to develop this, emicizumab. Emicizumab is nothing but, it's basically a bispecific antibody. What this bispecific antibody tries to do, it tries to bring down factor 9 and factor 10 together. Okay, so if you see in the coagulation cascade, factor 9 and factor 10 combination is more important because that is where the common pathway merges. Okay, so in the presence of factor 8, then factor 10 will activate factor 5, factor 2, and factor 1. So here it is doing an artificial job of factor 8 here. So this bispecific antibody brings factor 9 and factor 10 together and promotes the catalysis of factor pathway. Okay, so this is a independent mechanism of clotting cascade activations, and it has got a very good half-life of almost 30 days. And the important thing is this dose can be administered by a subcutaneous route. The other factors, we usually give it as a IV route. So this is usually given as a subcutaneous route. So there is an important, fact to note that the ease of administration is much better and easier here, right? Again, we have one more product called Mimhate, which is again doing the same job of bringing factor 9 and factor 10 together. So thereby promoting the clotting cascade. So now this emicizumab is available in all the government centers. Particularly, it is not available for treatment, but it is available for prophylaxis, wherein, instead of using factors as replacement prophylaxis, you can use emicizumab for replacement, and it can be easily administered. The first dosing only is initially like weekly once for first month, and thereafter you can, schedule it every 15 days to 28 days. So that is the advantage with emicizumab and this Mimhate therapy. And again, we have various other non-factor replacements. So till now, it's only the factor replacement and emicizumab. And now we come to other non-replacement therapies. So here again, as I come back to my initial slide, hemophilia is a disturbance between a balance of procoagulant and an anticoagulant. So here, since we have a deficiency of, factor 8 and factor 9 here, so anticoagulant is slightly taking an upscale higher. So the balance is slightly moving up here. So now, apart from concentrating on the procoagulant side, okay, which is by supplementing factor 8 or factor 9 or emicizumab, what are we trying to do is we are trying to inhibit the anticoagulation pathway. So of which anticoagulation pathway, whatever is coming to mind is first is your antithrombin 3 tissue factor pathway inhibitor and your protein C and protein S. So we all would have learned about this protein C and protein S deficiency in thrombosis. So same way we are trying to, promote thrombosis by creating an artificial deficiency of this protein C, protein S, antithrombin 3 and tissue factor pathway inhibitor. So I think this as in general physician practice, we all, whenever a patient comes to you with life-threatening thrombosis, we do this common test, right? Like antithrombin 3, protein C, and protein S activity. So similarly, in hemophilia care, what are we trying to do is we are trying to tilt the anticoagulation balance upward. So basically, to understand this, what does these three do? So here, if you see this tissue factor pathway inhibitor, this is the important pathway in initiating the extrinsic pathway. So now we have developed a monoclonal antibody to inhibit this tissue factor pathway. So that is an important non-factor replacement therapy. Second, again, we are trying to develop molecules at the genetic level to inhibit this antithrombin, because this antithrombin is going to inhibit thrombin. So we have a drug called as fitusiran, and that is inhibiting this antithrombin. So we are trying to hit the anticoagulation mechanism at that point of time. Again, to protein C and protein S, we have something called as serpin protein C, which is again a monoclonal antibody to protein C, which is trying to inhibit the protein C. So basically, by inhibiting the anticoagulation mechanisms at these 3 points, we are trying to tilt the hemostatic balance more towards a thrombotic phenotype. Okay, so thereby you can promote or prevent. Thereby you can promote thrombosis and prevent bleeding in these patients. But the important thing to note is all of these drugs which I have talked about, all in preclinical trials. They are in phase 1 and phase 2 studies. They are yet to come to clinical practice. I hope in the coming, in the next 5 to 6 years down the lane, we will have all these products available for clinical use. Okay, so this is just an overall overview of till now what are the various non-factor therapies that we have discussed for the prophylaxis of bleeding. Emicizumab is just like a glorified factor, which is a bispecific antibody that brings factor 8 and factor 10 together, which is just like an artificial factor 8. Whereas all the other 3 molecules that we have discussed, that is your fitusiran, concizumab, and serpin C, are all non-factor replacement therapies for the prophylaxis of bleeding. Coming to the last section or the last domain of topic, which is your gene therapy, and which is the most promising technique and which is the talk of the town these days in hemophilia, is gene therapy. So again, you need to understand here, as I told in the first slide itself, the factor 8 gene is pretty long and heavier, whereas factor 9 gene is pretty small and smaller. So that is why, to pack, so gene therapy is basically what we try to do here is, we would have read about this bacteriophage in our botany classes. So basically, again, we use a adenoviral based vector wherein we synthesize this factor 9 gene here. So this is how we do this therapy. Basically, the deleted factor 8 or factor 9 is incorporated into an adenoviral vector. It's okay. So basically, the factor 8 or factor 9 deficient gene is incorporated, it's artificially synthesized and incorporated into an adenoviral vector, and this is injected into the human body. So this vector goes to the liver. We all know that factor 8 and usually the factors are synthesized in the liver, because all these anticoagulation proteins and coagulant molecules are synthesized in the liver. So this adenoviral based vectors go to the liver, and inside the liver, they start multiplying. All these adenoviral vectors start multiplying, and they start producing coagulation factors. So that is why a patient who is having a deficient gene, with the help of this gene therapy using this adenoviral vectors, they start synthesizing factors easily. Okay, but once after doing this gene therapy, you can see that the clinically significant decrement in your annual bleeding rate, that is your ABR. But this gene therapy again is not without challenges. Okay, so again you have various infusion related reactions. We have a risk of insertional related mutagenesis, and we have some degree of hepatotoxicity being documented with this gene therapy as well. So, but over the years, with improvisations in your gene therapy techniques and modalities, I think in next decade, I think this will be the promising future for all our hemophilia, gene therapy patients. I mean, severe hemophilia patients. So I think with this overview, I'd like to end my talk here. So we are moved away from, conventional factor replacement to extended half-life factors these days. And we have now in our domain, we have various non-factor replacement therapies. And I think gene therapy is the one promising domain of patients, suffering from hemophilia, and which can change lives of patients with hemophilia. So with this, I end my talk, and thanks for the opportunity. Thank you.
Thank you, Gopinathan sir. This is an excellent speech. Your slides are very amazing and very good. And I think you spend more time for slide preparation. This is very excellent. Madam Margaret, madam, kindly give your input. Then we'll go for the questions.
Yes, thank
Madam?
you, Dr. Gopinath.
Yes,
Thank you,
madam.
Dr.
Yes,
Gopinath.
Yes, shall we go to the question? Yes, madam, kindly give your
Yes.
input, madam. We'll go to the next questions session.
No, I just wanted to thank Dr. Gopinath for a very comprehensive review of the management. So any questions can ask.
What will be the outcome of the result in either male or the female patients? The first question, madam.
Sorry.
Outcome.
Yes.
Outcome is good in either male or female patients.
Yeah, so usually the males are symptomatic patients because they are the ones who have only one X gene. So XY is male. So even that the contribution by X is only already 50% in them. So usually males are patients, and usually they are the ones who suffer severe disease. Since now we have gone.
DVT common in male or female, sir? Deep vein thrombosis, DVT.
DVTs, per se in hemophilia patients are not predisposed to DVT. So DVT is a separate topic in itself, actually. But with regards to hemophilia, males are the usual patients, and they have, of which the severe hemophiliac phenotypes are the one who suffer the most of the complications. But females, we usually tell them as carriers. We don't, usually screen them. But females, we have had some patients of carrier of hemophilia who have had significant postpartum bleeds, who have had significant menorrhagia. So it is essential that any patient with menorrhagia, it's imperative to rule out, carrier, particularly when they have male family members affected in their family. It is essential to screen them for factor 8 levels and then treat them accordingly.
So what is the maximal life expectancy?
If the patient is properly managed, we have seen hemophilia patients usually living till 30 years and 40 years also without any problem. And milder or moderate phenotypes, usually they live almost a normal life. I'm telling about the severe phenotype. So if they are properly managed on time, we have seen them living almost up to 30 to 40 years. But I think now with that, the more advantage towards using prophylactic factor replacement, I think we can expect a longer duration of life, because once upon a time this prophylaxis wasn't available because the government wasn't supporting supply of that much amount of supply of factors for giving prophylaxis. But now the NRHM and all the other national bodies are quite strong. WFH is again quite strong to support prophylactic factors, and I think now the quality of life will be much better than what they were managed in the earlier 2000s and 2010s.
Well done, sir. Thank you.
There is one question. Kindly explain the calculation of units again. Can you kindly repeat the same?
Yeah. So that is a basic formula, sir. Only thing is weight. So usually, depending upon the site of bleed, we ask for desired factor rise. Say usually for a joint bleed, we ask for 40 to 50 unit rise. For a gum bleed, we ask for 20 units rise. For a CNS bleed, we ask for 80 to 120 units. So depending upon each site, we have recommended factor level rises. So that factor rise into weight of the patient into the correction factor. For factor 8, the correction factor is 0.5, and factor 9, the correction factor is usually 1.1. So based on the dose will be divided into BD in case of factor 8 because the half-life is only 12 hours. Factor 9, it is 24 hours. So usually it is given as OD. And the duration of the duration of therapy also depends upon the site of bleed. In a joint bleed, it's as low as 3 to 5 days is enough. Whereas in a CNS bleed, you need to give it for 10 to 14 days. In a GA bleed, we need to give it for 7 to 10 days. We have a set of guidelines framed by World Federation of Hemophilia, WHF Guidelines. So whenever any patient of hemophilia comes with a specific bleeding, we see that chart and we prescribe our factor replacement therapies. Even if you want to take up for an elective surgery, prior to surgery, we ask them for a factor level. So based upon that factor level, we calculate the desired amount of rise, and then we also prescribe how much time post-operatively they need to continue the factors.
Okay, sir. Sir, in case of acute joint bleed, okay, we are the orthopedic surgeons, whether it is advisable to aspirate the joint immediately or the aspiration should be done after the factor replacement?
Usually we say that's a very tricky and important question that needs to be administered. So usually a joint bleed creates a tamponade inside the joint. Okay. So what we do is we initially try to we follow this simple price therapy. Unless there is a significant nerve compression or something, we prefer not to touch the joint. We try to rehabilitate with the joint and do away only with factor replacement and the so-called POLIS. Protection, optimum loading, ice compression, elevation, limb elevation. So we just try to manage only with a conservative management. Only when we fear impending nerve compression, which is highly decided upon case-to-case basis, we try to aspirate the joint. Otherwise, we with the bleed itself, we say that it tries to create an artificial tamponade. So we don't try to touch it. Whereas in a very critical site like iliopsoas bleed or CNS bleed, there we need to consider removing it in order to prevent overt limb compromise or overt limb damage.
So you are telling that
One more point I would like to add, sir. Just one more point in this.
Madam, yes.
One more point in this context. It's important to advise the patients to report to the hospital as soon as they feel a tingling sensation. Not wait till there is swelling and severe pain. That initial aura they get when there is a tingling sensation. So they should report early, those who are not on prophylaxis, in which case there will not be significant swelling and pain of the joint. So this is something that most patients will be able to identify, that initial tingling before there is a swelling or pain. They should report to the hospital immediately. That is the advice we should give these patients. And now the factors are available in all the district hospitals. So it is very easy for these patients to enroll in the hemophilia centers and get access to factors.
Madam, Dr. Margaret, air travel, hemophilia patient air travel பண்ணும்போது any specific precaution, madam?
Before? What's up? Before?
Air travel, madam. Air travel.
No, there is no specific precaution before air travel. It's only for thrombosis. Hemophilia is a bleeding disorder, sir, whereas thrombosis is a coagulation, clot disorder. They form clot excessively. So only when there is a DVT or a pulmonary thromboembolism, when there is a clot formation, before air travel, we will have to give anticoagulants like heparin. Not for hemophilia. They are bleeders. Hemophilia, they are bleeders.
Yes. Gobinathan, sir. Sir, Gobinathan, sir, how much percentage of patients are developing joint deformity after joint hemophilia? Do you have any data with you?
Invariable, sir. It's usually the factor bleeds are percentage, like it depends upon how well we manage the patient in the early part of life. So invariably, if the patient is not managed, if they have at least 5 bleeds in their lifetime, they do develop some type of joint deformity.
Oh,
so
5
that is
bleeds.
invariable. Yeah.
Okay. Any role of desmopressin in these patients?
Yeah, desmopressin is more for von Willebrand's disease. Though factor 8, I mean, there is a probable role, but it is more for von Willebrand's disease. But the hemophilia, the only role is with tranexamic acid and some degree of xylon aminocaproic acid. Desmopressin doesn't really play a major role here.
Any role of blood transfusion? Yes, madam.
Another important point about tranexamic acid is it should not be used in patients with hematuria. Hemophiliacs who come with hematuria, tranexamic acid should be avoided. Can be used in all other bleeds in hemophiliacs.
Madam, one last question regarding stem cell therapy in hemophilia. Is it useful or only theoretical?
Which therapy, sir?
Stem cell therapy.
Stem cell therapy, madam. Stem cell therapy. Recently, we are having regenerative medicine with stem cell therapy, madam. Is it very useful for the hemophilia patient?
Yes. For gene therapy is what is tried in hemophilia, sir. Gene addition or gene editing is what is tried. Gene therapy is tried, not.
Okay. Thank you, madam.
Sir,
very happy to see Dr. Margaret, old student of MMC. Welcome, madam. Dr. Sundaramurthy, pulmonologist.
Yeah, I could see that. Sir, I could see that.
Madam, Dr. Sundaramurthy sir is having maximum number of questions in this forum, madam.
Yeah, I could
Always
make out, sir.
He will stimulate your brain to read further.
Yes, sir. Yes.
Thank you, madam. All blessings from MMC, madam. Thank you.
Thank you, sir. And same to you, sir.
Yes, Sir Gopinathan, sir. Is it possible for the patient family to keep the clotting factor on their hand is possible practically, or they have to go to the hemophilia treatment center?
They have to go to
Just
hemophilia
for
treatment. Yeah, actually, out in general, we don't recommend doing that. But out of this is slightly for patient families. We ask them to, if they are traveling from a very much peripheral district of, I mean, the place where I did my DM. So suppose if they are coming from a very distant village of Uttar Pradesh or something, so we give them 2 factors for rescue use. So where we ask the primary healthcare practitioners to administer it and send it to us. That we do off-label. Otherwise, all the factor vials that are provided by NRHM, we are accountable for it. We need to send them back the vial, the badges, everything we need to send. So it is all accounted 1, 2, 3, everything by the government. So we are answerable for it.
Is it officially allowed to handle the factor with the family members? Because if they are in the primary health center areas,
officially it's not. Officially it's not. But then, if say for example, if we know that the patient is a severe hemophilia, and we know that this guy has so much annual bleed rate, we kind of allow them to take it and then give the first shot there, and then subsequently he will reach the hospital and get the subsequent factors here. Having said that, the need is coming down these days because we are trying to have factor replacement products at district hospitals itself nowadays. So previously the supply wasn't that much. Yeah.
Just one point here, sir. The government supply cannot be given outside, but patients can buy it and keep it in their refrigerator. For an emergency, they can buy factor concentrates and have it at home. The government supply cannot be given, sir, to the patient. They have to come to the center. That is the rule. They can buy it from...
Okay, madam. For how many days they can keep in their home, in the refrigerator? Is the maximum days of...
it's usually a freeze rate powder, sir. Stability is not a problem because you're going to freshly reconstitute and administer.
So stability is not a problem. They can keep there.
That is not a problem.
For a long time.
Yes. On paper, again, I'm clear. On paper, government product shouldn't go outside. But for this practical, say most of the patients are very poor and they come from a very distant part. So off-label, we kind of give them and then keep so that the first dosing is done there, and the second dosing itself, they should reach the government center.
So you have to register in the government center for the same for
yes.
replacement therapy. Okay.
Yes. And there are
it is completely free. It is completely free.
It's completely free. So because in private, we can't even think of doing factor rate and they are extremely costly. For a simple hydrocele surgery, patient has to spend more factors for doing more cost for doing hemophilia factor prophylaxis than doing the surgery itself. So it's very costly in private practice, but government is trying to give it for free. And there are many centers open to these non-factor therapy trials. So we have active emicizumab trials ongoing in many parts of the country. And emicizumab is given free across, even in MMC, it is given free these days. So that is one thing, good thing that is being done by government for these patients, hemophilia patients.
For the want of the public, sir, is the factor therapy and also the emicizumab is available in the Chief Minister Insurance Scheme? Is it available for the private hospitals? The patient can avail through insurance. Is it possible? Is it ordered?
I don't think it is available in CM scheme. The CM scheme, no, it doesn't give.
Not at ordered.
Not at all. Ma'am, I think I will use, ma'am.
Yes. See, sir, if a hemophiliac patient requires factor concentrate, he has to go to a government hospital or a district hospital and get the factors. Even surgeries, they can only do it in the government hospitals, sir, because the requirement of factors during surgery will be huge. And each factor, 1 unit of factor rate costs around 10 rupees, sir. So these patients have to have their surgeries also in the government setup only. Actually, in GH, we have done quite a few surgeries, orthopedic, patients with hernia, abdominal surgeries, all free of cost, but they have to go to a government hospital to get the factor concentrate. It is not in the CMCH.
Okay, Jayaraman sir, shall we close the session?
Yes, sir. Yes, Sendil, Adar Sendil, nice. Yeah, we can come to the end now. Yeah, proceed.
Okay, sir, we'll conclude the conclusion. Vote of thanks by Dr. Jayaraman sir. And a very nice session with Dr. Gobinathan Market, madam. Thank you very much. We have a great input about the hemophilia. Even I am an orthopedic surgeon, I get knowledge about the hemophilia. Thank you very much. This is definitely going to be helpful for the public. Thank you, sir. Vote of thanks, please, sir.
Thank you very much, all the leaders of IMA and delegates and the speakers and moderators. We had a wonderful session today for the commemoration of World Parkinson's Disease Day. Moderator Dr. Bhuvaneshwari ma'am and speaker Dr. Ram Narayan sir. So dealt with latest advancements in Parkinsonism. So medical treatment and surgical treatment. There are a lot of restorative neurosurgical procedures available for like deep brain stimulation and other pain management therapy and all. So we had a wonderful talk. Thank you very much, Dr. Bhuvana ma'am and Dr. Ram Narayan sir for the wonderful topic and this thing. Next, we have a wonderful talk on World Hemophilia Day, the Hemophilia update. So Professor Dr. Margaret ma'am so opened this talk with the nice wordings, and the speaker Dr. Gobinathan did a wonderful crisp and clarity update presentations of various levels of the factors. So men usually suffers female or carriers. So the symptomatology and the warning symptoms and how to transfuse the factor 8 and that is a replacement thing and all. So very nicely put up. I thank you, Margaret ma'am, for the wonderful moderation, and Dr. Gobinathan for the wonderful talk about the hemophilia update. And I thank all the members and the leaders for the wonderful thing, and the IT team, our IT team. So flawless flow of the event. So I request everyone, those who are not joined, IMA or IMA AMS, Academy of Medical Specialties, kindly join. So thank you very much. Long live IMA, long live AMS. With that, next month we'll meet again with a different topic. So thank you all. God bless. Thank you.